Our next section of disorders are our mood or affective disorders, where our affect is literally just talking about our emotional affect or how we are acting, how we're feeling, things like that, all tied together. So you might see it as mood disorders, you might see it as affective disorders, both refer to the same thing. But we're going to mainly focus on depression. We'll talk about major depressive disorder and then also just sort of acknowledge chronic depressive disorder. Then we'll move into our bipolar disorders, which not everyone knows that there are multiple kinds of bipolar disorder. Then we'll talk seasonal affective disorder, just again, sort of touching on and acknowledging its existence, because this is a crash course on our different types of disorders. But starting off with depression, clinical depression is specifically looking at a case where the frequency, intensity, duration, all of those things of our symptoms are feeling low and feeling sort of lack of motivation, sadness, despair. All of those things are out of proportion to the situation. So just like with our anxiety disorders, where experiencing fear and anxiety might be appropriate in a given situation, but if it is out of proportion, it is a disorder. Depression works the same way. There are times when it is valid to feel sad and despair and have no interest. You're apathetic towards things in your life, especially, say, following loss or something like that. But this is a case where we would call it a disorder if it is above and beyond what would be expected under certain conditions. And so we'll talk, so you'll usually see major depressive disorder is the one that's mentioned most often. When we talk major depressive, it's specifically referring to the fact that this is something that is long-term. So it has to last for, I think it's a couple of weeks, depending on which source you're looking at. So it has to be a prolonged duration. And oftentimes it occurs sort of multiple times. You might have multiple major depressive episodes within this disorder. Though we will see that some individuals will only have a single episode, and that is still sufficient to qualify for the disorder as long as that single episode was sufficiently long. But in either case, whether it's one episode or multiple, they're all in this instance where we have sort of very long-term persisting feelings of sadness, despair, lack of interest. You feel sort of this anhedonia, or reduced ability to experience pleasure. You're apathetic towards stuff. And while we have sort of that minimum duration of a couple of weeks to qualify for major depressive disorder as a diagnosis, some individuals might experience this for months or even years. Some people might have this experience their entire lives. It's very variable and has lots and lots of factors that can influence, as always, with our different disorders. This is another instance where our rate of diagnosis is changing dramatically, and there's a lot of discussion around why. So the rate of diagnosis in young individuals, basically under the age of, say, 25, that is massively rising. And of course, we can say, well, maybe it's because the economy, the environment, our day-to-day lives, we're surrounded by lots of very negative things in social media and in the news. So maybe that's leading to this lower state in general and leading us to be more likely to having long-term depressive episodes. But there's also, once again, that thing that younger individuals might feel more comfortable seeking treatment for depression, whereas older generations were raised probably with the mindset that when you're sad, you just have to suck it up and push through. So for these individuals, the younger individuals are a lot more likely to seek treatment. And if we look at the statistics, just sort of curiosity, not that you need to know the numbers, but people born after the 1960s are about 10 times more likely to experience depression than those in the older generations. So even though some of those older generations lived through a lot more traumatic events, things like the world wars and so on, younger individuals, sort of newer generations, are more likely to seek treatment. And therefore, we have to be cautious when looking at these sort of rates of depression being on the rise, because there are also still those biases in terms of diagnoses. Similarly, we see the difference between the sexes, where women are about twice as likely to suffer from depression as men, and they tend to experience depression earlier in life, whereas the men who do experience depression, it tends to come later in life. and might actually be part of the mythos of a midlife crisis, which we may or may not get to chat about later on. And then just like our discussion with anxiety, where we could talk about emotional symptoms and cognitive symptoms, we have the same here for depression. So with the emotions, we're talking about that negative mood state. You're feeling sad and hopeless, you're anxious, miserable. We actually find sort of this anxiety that a lot of anxiety and depression related disorders actually tend to be very comorbid, meaning that they tend to co-occur. So somebody with depression is also very likely to have anxiety and vice versa. So having one seems to predispose you to the other, which when we start looking at, say, our bipolar disorder and we see a mixture of sort of very high energy and very low energy, it might make sense that some of our different symptoms will co-occur. Motivational symptoms. So if you're having this inability to enjoy your day-to-day life, loss of interest, loss of motivation kind of makes sense, especially where doing something doesn't lead to the same enjoyment that it used to. You might be less likely to try and do things knowing that you won't enjoy it. With our cognitive symptoms, depression tends to involve sort of a negative thought spiral. Just like with anxiety, you can sort of work yourself up by thinking very catastrophically and having these very anxious thoughts that make you more anxious. Depression does the same, where the lower your mood state, the more negative your thought patterns are, which then tends to lower your mood state. And so this ends up causing what's called a depressive spiral, where the worse you feel, the lower you think, and the lower you think, the worse you feel, and you tend to spiral downwards. And it can be really hard to break out of that spiral, especially when you don't have any kind of social support. When it comes to somatic symptoms, we run into maybe some contrasts here, because some people might lose their appetite, but some people might actually gain an appetite. So when you're in a low mood state, you might just not have the energy to eat at all, or you might not be able to stop eating. You might compulsively eat because you want comfort foods and things like that. So this can lead to either weight loss or weight gain, depending on the individual. You can have issues with sleep, which once again, you might sleep too much because you're so exhausted and tired of the world and it's just easier to be asleep. Or you might be unable to sleep, constantly tied up in all of those negative thought patterns. Lack of energy is going to be that low mood state, low motivation, ties into having very little energy. So all of these kind of end up tying together, but again, showing that there's some variability here. Different individuals will experience the same disorder very, very differently. As I mentioned earlier, when we said that people who have this diagnosis of major depression, some of them are going to have multiple depressive episodes. So when we break it down, about 50% of people who get this diagnosis are going to have multiple depressive episodes. They might be spread out across months, years, decades, just repetitive occurrences of those depressive episodes. That's all that's required to fall into this category. A pretty big chunk of them will have a single major depressive episode and it will never reoccur. So this might have been maybe triggered by a pretty traumatic life event, something big going on in their day-to-day lives. It might just be sort of one instance of really strong chemical imbalance. Things like pregnancy can influence hormones and cause major shifts in how our brains function. So that could be responsible for a single very bad depressive episode that would never that would never reoccur. But lots of different reasons why you might have a single episode. And then a small portion of people, about 10%, will have chronic depression. So they will have sort of periods where they are pretty much always depressed. So unlike this sort of blue-green portion here, where we'd have periods of depression followed by periods where they are not depressed, this would be sort of always in a very low mood state. So their experiences, their affect would be low all the time. Now, this portion here where depression reoccurs, so you have periods of depression and periods where you are not depressed, that's actually something that's hard to differentiate from one of our types of bipolar disorder, which we'll get to in a moment. But first, let's talk bipolar disorder. So we have two different types. I will mention a third category that's similar but not called a bipolar disorder. But we have bipolar 1 and bipolar 2. And when people talk about bipolar disorder, they're almost always talking about bipolar 1. And this is the most extreme, the most visible, the most iconic version. So bipolar 1 is when you have periods of depression that alternate with mania. So those depressive states that I mentioned when talking about major depressive disorder, those are what we're talking about here. So bipolar involves a lot of the same symptoms as depression. The difference is that the alternating periods of mania are almost like a complete mood swing in the opposite direction. So mania, this manic state, is going to be high energy. You tend to be really motivated. You tend to be able to do lots of things that you couldn't do before. You feel like you can accomplish anything. So this is sort of a drastic swing in the opposite direction. And just like having a single major depressive episode is sufficient to qualify for major depressive disorder as a diagnosis, a single manic episode is sufficient to get a diagnosis for bipolar disorder. Suppose I should also mention, sort of if you go back in time, this used to be called manic depressive disorder, just because you vary from mania to depression, but the more proper term now is bipolar disorder. And more in sort of the naming conventions here, if this is bipolar, meaning we have two poles, two polar opposites in terms of activity, so very, very low mood states with depression, very, very high mood states with the mania, major depressive disorder is actually sometimes called monopolar depression, meaning that it only has that low side, that low pole of our spectrum. So kind of interesting to see that. And actually, I should probably hop to this slide here that shows that once again, we have emotional, cognitive, and sort of physical characteristics that tie to bipolar, but we get to see the differences between mania and depression here. So for emotions, if depression was sort of low mood, feeling hopeless, socially withdrawn, irritable, manic episodes will lead to sort of these feelings of elation and euphoria. You are impatient and high energy and go, go, go all the time. Cognitively, mania, usually your thoughts are moving really quickly. You tend to want to be in action. You are impulsive and talkative. And this delusions of grandeur is you tend to feel overconfident, like everything is going your way, that you can do everything and have no wrongs. Whereas depression would be the opposite. So delusions of guilt would be things like you feel unworthy, you feel lesser than you are. You have a very negative self-image, you tend to blame yourself for things that have gone wrong, and you tend to catastrophize. You're also a lot more slow in your thought patterns. And then motor side of things, so depression being low motor, low energy, low motivation. Mania tends to be high in all of those things. So again, complete opposites, polar opposites as it were. Now, before I move on, I want to make sure I talk about bipolar 2 disorder. And this is the one that's actually very difficult to differentiate from these individuals who have depressive states with periods returning to normal. So bipolar 2 is when you have periods of depression that alternate not with mania, but with something called hypomania. And hypomania is basically like a lower level of mania. You're not quite manic, you're not quite sort of the extreme, you're not super energetic, you're not go, 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 but you do have higher levels of energy than a normal baseline. The reason why this is really hard to tell apart from people who just have major depression with periods without depression is we need to know what someone's baseline should be, because hypomania is only slightly elevated mood from a normal state and therefore can be really hard to tell apart. So it's much easier to diagnose bipolar 1 than bipolar 2. This one tends to go hidden because it will fall into just a major depression diagnosis and be missed completely. And I did mention that there is a third category here that would fall underneath, just in case you're curious, and this is something called cyclothymic disorder, which is basically like bipolar disorder, actually, so it's closer to bipolar 2 disorder, sorry, instead of saying 1, bipolar 2 disorder, but they cycle very, very quickly. So with bipolar 1 and 2, you tend to see that these cycles are going to be across, say, days or weeks, depending. But with cyclothymic, the cycles are very fast. So you might cycle rapidly, maybe even within a day. You can have multiple switches between sort of low levels of depression and that hypomania back and forth very quickly. So it comes across as almost having sort of an unstable mood where you can't really predict that individual's actions. It might be related to that. But bipolar 1 and 2, the switches tend to be less frequent, so not necessarily multiple times a day, but maybe a day or two or more in between them. And then, of course, if we start talking about sort of prognosis, or not prognosis, who tends to get this diagnosis, in this case, we tend to see about equal diagnosis between women and men. So in this case, it's not that women are more likely, like we saw with major depression and a lot of our anxiety disorders, equal distribution. And this tends to be seen in about 4-ish% of the population within North America. But as always, our numbers are not really the important part. And then, of course, at the very, very end, seasonal affective disorder, or SAD. This is something that I always mention because living in Edmonton, we are really close to sort of those northern areas. And this means that we have very long periods of darkness coming into the winter. So seasonal affective disorder is basically this pattern, a seasonal cycle of depression, where people tend to have very low mood states as we spend more and more time in darkness. So we can also call this a circannual rhythm, which is basically saying that it cycles every year, as opposed to, say, a circadian rhythm, which cycles every day. But yeah, this is just saying that in the winter, people's moods tend to be much lower. And if that shift in mood is sufficiently severe, you can qualify for a diagnosis. So this tends to get worse in more northern areas, but also more southern areas as well, though there are fewer land masses very, very south. But all we need is the fact that in the winter, you tend to get very few hours of daylight, and lack of exposure to daylight tends to throw our systems out of whack. So not only does it cause problems when we start looking at things like our wake up cycle, waking up and going to bed tends to rely on our systems being reset by the presence of light. So having the sun not rise until, say, 9 or 10 o'clock in the morning, you can actually find that you feel more tired, you have less energy, you're slower to get moving simply because you didn't have exposure to light. There are also things like vitamin D is associated with sunlight, so we have lower levels of that as the winter goes on, and all sorts of other things. So by having seasonal affective disorder and these lower light levels, we start seeing people lower mood state, they sleep more, they have less energy, they also eat more. So all sorts of symptoms that can be tied to it. And something they've tried is phototherapy, which is, as it sounds, using light as a therapeutic approach to try and give you that exposure to light to help your systems reset. Also, if you can have exposure to the right kinds of light, it can help with those fluctuating vitamin D levels, and so on and so forth. Once again, our discussions of biological factors are going to be unsurprising, where we have our monozygotic twins are more similar than dizygotic twins in terms of our mood disorder diagnoses, which just tells us that if identical twins are more likely to share a diagnosis than dizygotic or fraternal twins, there's a genetic component here. And there's a stronger genetic component when we look at a bipolar disorder diagnosis than if we look at just a major depression diagnosis. So bipolar disorder has a stronger genetic contribution from most of the research we've seen so far. Our understanding of sort of what's leading to this, a lot of studies are going to point to underactivity of a bunch of our neurotransmitters, so specifically norepinephrine, dopamine, and serotonin when looking at depression. Since bipolar disorder includes both depression and mania, a lot of the theories tie to the fact that maybe there's a problem with regulating these. It isn't just that they're underexpressed, it's that they might be periodically underexpressed and at other times overexpressed. So having that cyclical nature might explain the shift between depression and mania and back again. And for sort of a trick on remembering some of this, so serotonin is tied to depression, and one of the most common things we'll talk about in treating depression are our selective serotonin reuptake inhibitors, or SSRIs. So they're going to try and keep serotonin acting for longer, and by doing so, lessen the symptoms of depression. So that might help you remember that serotonin is tied to depression, since one of our antidepressants, it interferes with serotonin cleanup. So we keep it active longer, so it ends up being more effective. We get more of a sort of activity caused by serotonin. When we look at some of our sort of other psychological perspectives, getting into our psychological factors, again, we shouldn't be too surprised. We've mentioned depression before, especially in our chapter on personality. So there are certain personality traits that tend to predispose you towards a depression diagnosis. So we've mentioned before, high neuroticism scores tend to correlate with higher levels of depression. And that makes sense if we remember that neuroticism is all about sort of that catastrophic thinking, that being easily worked up, but also putting yourself into more stressful situations and experiencing that stress more strongly, having it predispose you towards depression and other disorders kind of makes sense. So we can talk about it as a personality-based vulnerability. We have this personality linked predisposition towards things like depression, simply because of negative thought patterns, low self-esteem, and putting yourself in those situations. Optimism and pessimism, once again, can tie in here, where being pessimistic tends to affect your thought patterns. Same basic idea. Negative thought patterns, negative self-perception predispose you towards depression. If we asked a psychodynamic leaning psychologist what influences the diagnosis of depression, they would focus on childhood experiences, specifically childhood losses, especially if they're traumatic. But also, there's a strong focus on rejection early on in life. And the fact that feeling rejected might make you feel like you don't belong and be more self critical, things like that. If we look at a humanistic perspective here, we're focusing more on how the individual thinks about themselves. Again, unsurprising, focused on humans and their concept of self and their concepts of motivation and what they can acquire and achieve through their own actions. So, in these cases, individuals with depression might define their self worth in terms of their individual attainment. So, if they haven't accomplished a lot in their lives, they might be more likely to see themselves as failures, and that can set off some negative thought patterns. Of course, then they're going to react a lot more strongly to failures, but also the lack of successes can also be triggering here. And so they're going to attribute all of these failures to their own inadequacies. Again, not putting it on external forces, they're attributing things going wrong to their own personal failings. So we've talked before about that depressive framework and how rather than as people without a depression diagnosis would frame things, where they'd say that they are responsible for their successes and the world is responsible for their failures, individuals with depression do the opposite, where they will take credit for their failures and say that it's situational for any of their successes. They won't take credit for success. So those thought patterns tend to set you up to experience depression more sort of deeply. And they also sort of start feeling, well, if I'm not accomplishing anything, maybe there isn't any meaning to my life. I don't feel motivated. I don't have this desire to attain self enlightenment or self achievement or anything like that. And therefore, they don't have that same motivation, that same drive. Cognitive factors. We've already talked about our negative thought spirals tied to depression. This is also sometimes called the depressive cognitive triad. So you tend to think negatively, not just about yourself and your accomplishments, but also the world around you and the potential for the future. So if you feel helpless in the moment and you feel like your actions will have no impact on the future, you don't see any reason why you should try and improve the present because it's not going to matter anyways. So a lot of these sort of tie together with concepts we've already mentioned. We also start seeing those negative thought patterns leading to things like, well, when you're in a negative mood, when you're in a negative state, it's easier to recall negative memories. So you over remember times where things went wrong, times you were sad. And also, it's harder to remember happy things, and therefore, you're going to be less likely to be able to remember times you were happy, times you were successful, times you accomplished things. And then we already talked about those attributional patterns where we frame things in the opposite direction if you have a depression diagnosis versus not. And then, of course, learning factors, having experiences where things have gone wrong, where maybe you've tried to take action, tried to get something to happen, and it didn't work. those learning patterns are going to set you up to be less likely to try in the future. You feel less like you have control and influence in the future, and are therefore going to be more likely to have that sort of dispassionate, I have no impact, I have no role in my world, and therefore I'm not going to bother trying. So you tend to feel lower because of those prior experiences. And then just looking at this diagram here, this is talking about the fact that because we have that sort of reduced experience of pleasure and enjoyment from actions that used to be enjoyable, we can actually see that people can try and seek out those feelings of enjoyment, and maybe it doesn't work. So I did the thing that usually makes me happy and it didn't make me happy, which can actually then make you less likely to try and do that action again in the future. So you don't try the thing that should make you happy, meaning that the less sort of actions you're taking to try and make yourself feel happy, the less chance you will actually start getting enjoyment from any of your actions. And then you're going to feel lower and lower mood because you're not actually encountering these situations that used to be really motivating and enjoyable and positive in your life. So it tends to be, again, sort of this negative building thought spiral. And then if we look at sociocultural factors, there's a lot of differences across cultures. This again could be based on sort of cultural norms, the fact that it might be appropriate or not appropriate to seek treatment in any of these areas, so that affects diagnoses. But also we have things that might be more likely to make you feel low or feel unsuccessful or feel bad about yourself. Those could be playing a role as well. And again, differ between cultures based on what those cultures prioritize, how they think about things, how they talk about things, and so many other forces. If we look at things like feelings of guilt, feeling inadequate, in areas like North America, Western Europe, looking at a bunch of our individualistic cultures, a lot of societies or a lot of areas there, countries in those areas, there we go, are going to focus on individual accomplishment. And a lot of it is driven by competition between individuals. So at work, you're going to compare yourself to others. You're going to look at how somebody else your age is doing in life. So maybe you're not as far along as a sibling or as a colleague, and you feel bad because you're comparing yourself to them. In individualistic cultures, that's going to be very common because you're always focused on yourself, the individual, and you want to be doing the best that you can do, but it leads to a lot of comparison. Whereas in other parts of the world, specifically collectivistic cultures or collectivist cultures, those are more focused on the success of the group, and therefore the individual is a lot less important. So you would look at the successes of your community as your own success as well, and therefore you might be less likely to take on sort of those negative thought patterns about yourself as long as the community is doing well. So again, lots and lots of variation between cultures due to a lot of other factors that we've talked about for other things as well.